Hi, welcome to You Didn't Get the Memo. I'm your host, Gloria Bailey Ray. I'm excited that you decided to join us. Happy Saturday to all of you, and happy Halloween to those of you who are celebrating this October 31st day, 2020. Again, we have a fantastic show for you, and I am so excited to be able to bring to you this particular show. But let me remind you that our show, You Didn't Get the Memo, is a community focused show that provides you, the viewer, with relevant, factual, mainstream information to help you be informed and to make informed decisions. Now, many of you today who are watching, you either know someone, you yourself, you have a family member, somehow your life has been affected or impacted due to autoimmune disease disorder. You may have questions, and we're hoping to be able to answer some of those questions for you today. There are about between 80 and 100 autoimmune diseases that, right now that we know of. Some autoimmune diseases are more common in certain ethnic groups. Certain autoimmune diseases tend to run in families. And, there are a lot of factors that contribute to autoimmune diseases. Today, my guest, Dr. Eleanor Anderson Williams, who is a rheumatologist, is here, and she's going to be talking with us about autoimmune diseases. Let me tell you a little bit about Dr. Ellie. After she went to medical school, she completed a residency in internal medicine, and then she went on to do a subspecialty in rheumatology. We want to find out what was it that caused her to actually look at doing this subspecialty in rheumatology. She's dual board certified as a rheumatologist, and she's actually been in clinical practice for 16 years. So I want to welcome Dr. Ellie. Thank you so much for tuning in, joining us. I'm excited to be able to have you. So let's see. Dr. Ellie, are you there? Can you hear me? Hello?
Hello.
Yeah, I can hear you.
I seem to have lost audio. Give me just a moment.
Yeah, I can hear you fine. All right, guys, always a little technical difficulties. Dr. Ellie, are you there? Can you hear?
I can't hear you now, so hold on.
Yeah, we can hear you fine. Okay, let's see. Well, let's see.
Can you hear me?
Yes, absolutely. Yes.
All right, perfect. My apologies. It seems that my audio was temporarily lost. Good afternoon, everyone.
Yeah. Oh, I think that, people can actually hear you.
Perfect.
We can hear you. Absolutely. So if you can hear my questions, let's talk a little bit about what made you decide to go into becoming a rheumatologist.
Sure. So I suppose there are three really parts that drove this decision. The first was just deciding to become a doctor, and that happened when I was 9. My younger sister was ill, and during the time I saw her in the hospital, really behind glass, I wasn't able to see her directly. It made me feel in a way helpless, and the only way I thought I could help is that when I grow up, I want to become a doctor. Followed by that, in college, I had the most amazing biology professor. She taught immunology, and that really allowed me to become truly fascinated by how the immune system works. And so that by the time I entered the field of medicine in my residency program, when I encountered cases where the body would react against itself, it really just drew me in. I can share a bit more about this specific case even because it really was very impactful. But I've always been fascinated by how the body works, and in this case, how our immune system, the fighting or security force in our body, how it operates. And
Mhm.
so when I began to see cases where people's own body would turn and attack itself, and it could affect the skin, the joints, even the back of the eyes. It really was just endlessly fascinating, and I wanted to understand it better, and then more importantly, understand how I could help treat it.
Mm. Oh, okay. So that's, I love that. And of course, I definitely want to hear you talk more. But let's start with just a general overall idea for our viewers to know what is, and when you say an autoimmune disease, what are we really talking about here? What does that mean?
Sure. So I always think about it first as, well, how are things supposed to work? Because if I understand how it's supposed to work, then I can understand what's happening when it's not doing its job. So our immune system, as I was sharing, is really our security force, right? They are there, immune cells that communicate with each other to identify invaders like germs and other things. Our immune system also helps detect cancer cells and other important work. So obviously our immune system is crucial. The flip side of what I do is the allergy immunology department, for example. They take care of patients when their immune systems don't work. Um, they may have deficiencies in certain areas where they're not allowed to fight back. In the autoimmune world, though, in the world that I basically live in, the body turns on itself. So imagine for a moment that your immune cells are supposed to react against measles. Let's just pick that. But instead of reacting against the measles virus, it instead turns and attacks a joint, the lining of the joint. That cascade then kind of snowballs into a full blown attack where the immune system then goes and sends cells to the joints, as in the case of rheumatoid arthritis and others. And that, what we call inflammatory cascade, just magnifies. So those immune cells and go to places they don't belong, and then they recruit more immune cells to come and they go in attack mode. And that's what makes some of these diseases so destructive. So basically, again, it really is when the body turns on different organs and attacks itself rather than attacking the invaders and other things like that.
Yeah. Okay. Well, some autoimmune diseases seem to affect certain patient populations more so than others. So, in terms of the types of autoimmune diseases that you treat, what is it that you see?
Right. So great question. And there are so many different types of autoimmune diseases, right? And there are so many reasons people develop them, that genetics and ethnicity, that plays a part, and sometimes an important part, but that of course is not the whole story or the whole memo if in this case. So for example, in rheumatoid arthritis, we see even in Native American groups, there are higher rates, 10 times higher than the average population. We turn our attention to a different disease, systemic lupus, and we find that in women, it's often 10 to 1 as compared to men. Worse in African American and other Black populations, the Hispanic community, and so forth. So, what we find is it really does depend in part on the specific autoimmune disease. We tend to see things that are generally female predominant, but there are a few diseases that can affect men more than women, as in the case of something called spondyloarthritis. And so the important thing to know is when we are evaluating our patients, one of the reasons we ask about ethnicity, background, family history is really to help us kind of understand what is your risk in developing a specific autoimmune disease.
Hmm. Okay, so with that, a question, and by the way, thank all of you who are tuned in and asking questions, because people, as I said, this is a really big topic. It's something that so many people, and personally myself, having been diagnosed with an autoimmune disease, of course, totally blew me away, but it's taken several years before it came to fruition and finding out what it is. But can someone have more than one autoimmune disease? Is that possible?
Unfortunately, absolutely. My mentor at UCSF actually did a lot of the genetic studies, And that while that was not my area of research, we looked at multiple autoimmune diseases in families. And so not only can more than one autoimmune disease exist in a family, to your point, more than one autoimmune disease can exist in a person. Let's come back to something like rheumatoid arthritis. That is one of the forms of arthritis that's characterized by swelling, stiffness, and pain. But about a third of patients with rheumatoid arthritis also suffer a second condition that some of the viewers may not have heard of, Sjogren's syndrome. And
Mm.
Sjogren's syndrome is when the immune cells attack your saliva glands. So then instead of producing a healthy amounts of saliva, the patient does not. And so their mouth becomes very dry, which can lead to excess cavities. The eyes are very dry. And so that's just one case where you can see more than one disease. Patients can get rheumatoid arthritis and lupus and multiple sclerosis. So unfortunately, the presence of one immune disease doesn't prevent us from getting another one. And there are even diseases that we can call overlap connective tissue diseases. And that term, for example, is meant to describe exactly what you're driving at, which is people who have more than one autoimmune disease. So we don't call it lupus. We don't call it scleroderma if they have more than one feature. It's actually called an overlap connective tissue disease. Thinking about that from a rheumatology point of view, we see that all of the time, but I want to call attention to something else, and that is that not only can you have more of the what I call the cousins, like the related to diseases, lupus, scleroderma, etc., you can have other autoimmune diseases like the thyroid or autoimmune hepatitis. So unfortunately, these can occur in multiple events.
Yeah, wow. That's good to know. A little frightening somewhat, but good to know. Thank you for addressing that. But here becomes another question. Yes, you had
I was
something.
just going to say that a key point, because I want to make sure the viewers also hear this, and that is, for example, if you come to see a rheumatologist with joint pain, one of the common things we would think of is something like rheumatoid arthritis, but precisely because we're kind of thinking, you can almost see our brains work at times, because we are thinking about what are the other possibilities, you'll find that you'll go through a broader batch of tests than for more than just rheumatoid arthritis, so that we don't overlook something like lupus or another autoimmune disease that can happen together or produce some of those same symptoms. So I just wanted to call that point out because it's a really important one. And hopefully by hearing that, it can also help offset fears about, can I have more than one? Generally, we're going to check for that.
Yeah. Oh, okay. That's awesome. And that's really good to know. Now, one of the things that, of course, as a woman, that I hear a lot of other women, it seems that, autoimmune diseases, especially things like lupus, MS, Sjogren's disease, that women, and especially women of color, seem to be affected more by that than others. And I love to hear your take on that, or what your thoughts are in regards to that, please.
Sure. So one of the interesting things, and so I'm not a pediatric rheumatologist by any means, but I will say that it's really interesting that in the lupus cases, for example, in pediatrics, so we're thinking basically pre-hormonal, right? Not as much estrogen. The cases are closer to symmetric, but you're absolutely right. 15 to 60, let's take that window, for example. Many of the diseases I treat as other rheumatologists predominantly affect women. And then even more sobering and humbling is I look in the mirror and say, gosh, this affects people who look like me. In the case of lupus, which is what I come back to that because that's probably the prototypical autoimmune disease. If we're going to talk about one in general terms, that's usually one we focus on. Lupus, for example, just is not only can it onset earlier, it tends to have a more aggressive course. And I have to tell you, it's not fully clear why it is different among ethnic groups, but particularly people of color. We know that African American and Black patients with lupus tend to have more renal involvement, so kidney involvement, worse prognosis. And this actually causes me to pause and say, even in terms of treatments, Research is a hot topic these days, but the reason I bring that up is because we know even from our research studies, where they might have a few more patients of African descent, the treatment protocols and regimens may not be as effective. So, for example, there are ways we treat lupus kidney disease in the European population that are not as effective in our patients of African descent. And so obviously as a rheumatologist, I have to know that. The reason I brought up research is it speaks very loudly to the fact that we need to understand what the genetic risks may be, and even in terms of our response to treatment, why that is, so that we can make more informed decisions as your doctors to properly treat the patients. Lupus is one of those diseases, for example, where men have a worse prognosis. Younger men, if they get lupus, they tend to have a more aggressive course. But again, if you line up 10 lupus patients, about 9 of those patients, if not all 10 at times, are going to be women. Of those women, the vast majority are going to be of African descent, Hispanic, and Asian Americans. They tend to have the worst outcomes, unfortunately. And again, it's not entirely clear. Some of that is gender, some of that is ethnicity, but some of it is unclear in terms of environment and perhaps healthcare disparities. That's probably the elephant in the room, is the fact that if a patient is of a minority background, if there's differences in access to healthcare, access to treatment, unconscious bias that may cause delays in treatment, and all sorts of reasons why, unfortunately, those who are afflicted most greatly sometimes lack for treatment. And I would also say education, right? I have to take the time and explain. That means I have to even believe that you're going to be able to kind of process all that I'm saying. And I take that as a responsibility to really educate, so that we know that, yes, there is a difference. And if anything, we should be more vigilant. We should be vigilant for all of our patients. Right. But if I know that your outcome is more as a threat, then I've got to be even more vigilant and make sure you're empowered and educated. So, okay, I've got to get my blood work done. If they've asked me to take these medications, I need to understand why, what will they do, and so forth, right? But that requires a lot, an investment really on both sides.
Right. We're going to take a quick break, and I'm going to say to our viewers, don't go anywhere. And when we come back, we want to continue this dialogue, as I say, delving into discussing autoimmune. So don't go anywhere. We'll be right back.
If doctors, nurses, and grocery store clerks can wear a mask for 10 or 12-hour shifts, you can wear a mask for an hour or less when you go to the store. Do your part. Mask up, America.
I work out every day. COVID won't kill me.
I'm 24. COVID won't kill me.
I have antibodies. COVID won't kill me.
It's been a long week. COVID won't kill me.
I'm 25. COVID won't kill me.
I'm partying outside. COVID won't kill me.
I don't need to wear a mask around my friends. COVID won't kill me.
I'm 23. COVID won't kill me.
If I haven't gotten it yet, COVID won't kill me.
I'm young. COVID won't kill me.
Famous last words. Don't let them be yours. Socially distance. Mask up, America.
Hi, if you're just tuning in, listen, you have missed so far a fantastic discussion with Dr. Eleanor Anderson Williams, a rheumatologist, and we're talking about autoimmune diseases. Before we went to break, Dr. Ellie was talking about, she touched on a number of things, and I want to go back to what she was saying, because, the treatment of autoimmune diseases, it involves all I would say all hands on deck, entire healthcare teams, but also things that she was talking about in terms of what you must do to do your part. So I want to bring her back in. Dr. Ellie, before we went to break, you had started to talk about things that people, patients need to do as it relates to dealing with their symptoms, their diseases. And I just said it's kind of a all hands on deck because it's a full, what I would say is a full complement of healthcare professionals, which includes your primary care physicians, which includes you as a specialist, but also all those other things and being aware. And I can just tell you, just certainly trying to figure out with my own autoimmune disease, the medications that I have to take, getting blood work every 2 to 3 weeks, all of those things. And whereas it may seem like it's a lot, but you know what? I actually feel, and you use this word, empowered to be able to say, hey, look, I'm also a part of this process. I'm not just on the outside looking in. So I love the fact that you've talked about and you kind of led into what patients need to do as well, but from a physician's perspective, because we had talked a little bit before we went live about some of the things that you treat as a rheumatologist. And you know, I know that there are people on here talking about lupus and they're talking about Crohn's disease and they're talking, you know, all kinds of things. But will you tell our viewers, as a rheumatologist, what it is that you treat the most of and how other things are referred out to other specialists?
Right. So I thought about this a lot because the autoimmune world is huge, right? There are neurologists who tend to manage multiple sclerosis. The gastroenterologists, if you mentioned inflammatory bowel disease like Crohn's, they tend to manage that. Our metabolism experts, the endocrinologists, tend to manage the thyroid diseases. So I kind of asked, well, how do we fit in? And the best way that I can explain how a rheumatologist fits is we tend to manage the autoimmune diseases that also trigger a bit of inflammation and tend to be systemic. So we most commonly, for example, back to lupus, treat systemic lupus erythematosus, but the skin doctors may commonly treat if it's skin-only lupus, which does exist in several forms. We also treat conditions called vasculitis. Those can be quite serious and frankly deadly, unfortunately. And those diseases are occurring when the immune system attacks the lining of our blood vessel walls. We do treat sarcoidosis. That's a different condition that causes something called granulomas, which is basically clumps of inflammatory cells attacking. These granulomas can go all over the place. If sarcoid is occurring mainly in the lung, then often it's the lung doctor, the pulmonologist that manages it. We manage the forms that cause arthritis, so things like rheumatoid arthritis. Some of your viewers may have heard of a condition called scleroderma, and so there are a whole host. And I want to point out that in addition to autoimmune diseases, which is sort of our bailiwick, the thing we do the most of, if you will, we also manage a few other inflammatory forms of arthritis if the primary care physician is not able to do so. So for example, we do periodically see cases of gout, not often unless they're not responding to the usual treatments. We also see something called pseudogout, and we also see a condition called polymyalgia rheumatica. So that is the short list, just a few of the things that we see as rheumatologists. And I would say to patients that, you know, your primary care doctor really is the captain of your team. So make sure you have someone that you feel comfortable and confident talking to and sharing with, someone in whom you feel heard, and hold us to that. And so, for example, if somebody were to come to me and it turns out that their particular autoimmune disease is not my area of expertise, then either I would help refer them to the appropriate specialist or make that recommendation back to the primary care doctor. Because as we kind of talked about earlier, some of these things kind of go hand in hand. So it really does come into all hands on deck. And that matters whether you belong to an integrated kind of healthcare system or if you have to travel to different areas. You want to have that sense that the team is looking out for you in all aspects to make sure that your health is restored.
Yeah. Oh my gosh, you hit on so many points, Dr. Ellie, and I would just say kudos to you for acknowledging that, because look, I want to read a couple of comments online. One of the comments is that one viewer is saying that their partner had sickle cell anemia and lupus, had suffered for years because no rheumatologist wanted to confirm a diagnosis. Mm-hmm. And it actually took her finding an African-American doctor to be open-minded and realize that the sickle cell may have I guess, influenced or inflamed the lupus. And many of us go through this delay of diagnosis and therefore treatment. And so what you're talking about is so critical. And again, that kind of goes back to the discussion about healthcare disparities and what people are accustomed to. But you've got to be open. And I know some people feel a lot more comfortable with talking with their physicians that may be more like them. You and I had that conversation when the patient comes in, the person is an African American patient as opposed to maybe someone else of a different ethnicity. But the bottom line is having someone on board, a team of doctors who really recognize this person keeps coming in. And I can honestly say for me, it was one of those where I'm not one to complain a lot. And so, in my case, the autoimmune, it totally affects my face, my lip, my throat, and it's horrible. And you kind of look like, at least my word, something out of a Cyclops movie, and you don't want to go out. But thank goodness you had a care team that recognized and said, no, this has occurred before, and this is what it is, and involve me in the treatment. But it's really unfortunate there really are people out there who've not gotten that diagnosis. So I guess those last parting words for that particular comment, what would you say to that person as it relates to if they're having these symptoms, what could or should they be doing?
So great question. And really thank you for calling that to the forefront. A couple of thoughts just based on what I've heard. That comes back to sort of in training, we tend to think that we're going to explain most symptoms by one diagnosis, put everything in a nice, neat box. Part of our role, though, is to figure out when things are not fitting perfectly into that nice, neat box and consider other diagnoses. I saw it actually was on social media, a medical website recently about something called confirmation bias. And I don't mean to get too technical, but I want to call it out because I want to own all the different ways we might result in a delayed diagnosis, even if it's not intentional. And that is, let's say I see somebody and I'm convinced they have disease A. And so as I'm asking, if I'm not careful, as I ask questions and kind of listen to the story, I might be looking for things and kind of giving more power to the things that fit what I think the person has, and perhaps be a little bit too dismissive on occasion about things that may not fit the narrative, the story that I've already built. Take the case of sickle cell and lupus. To me, while I don't treat sickle cell, those two things don't tend to occur together. I'm aware of that. But the fact that they don't tend to occur together doesn't mean they cannot. And so I have to be aware enough. And one of the challenges with autoimmune diseases, we talked about this earlier, even outside of health disparities, is, as I have to admit, because I live in the body of a woman and I work in medicine, when a woman comes in and says something like, I'm tired, the first thought is not going to be lupus, right? I've got to look for other evidence, but that means I have to, key is look, ask. And so these are the kinds of things we have to really consider. So for example, to the people listening, when we think about somebody with lupus, one of the challenges I'm aware of is that sometimes a diagnosis is not immediate, and that occurs for several reasons. True, it might be because the person wasn't heard, but please also realize that sometimes the disease builds gradually. So if I have a little bit of thinning in my hair, for example, that can go on for a number of years. That may be an early sign of lupus, but you can imagine there are lots of people with thinning hair, so everyone with that symptom doesn't have the disease, right? Mm. So I've really then got to look and listen and inquire. And so we look for things like, am I sensitive to the sun? Like, do I produce a rash in the sun? Are my joints swollen? I've talked about the thinning of the hair. As the weather changes this fall now, one of the things we also look for are if the fingertips are changing color in the cold weather. So I would say this to you listening, to think about, gosh, if I'm having some of those symptoms, and that might invite further questioning. Further questioning can lead to further testing. So I would say, I realize that as a patient, you don't have a differential diagnosis to label a disease, but you can sense if something just feels not right. This doesn't feel like my usual sickle cell crisis or something like that. then it becomes more of a conversation. And it's okay to say, gosh, I did a little reading or reviewing, I'm concerned about da da da. That might be enough to cause a clinician to say, didn't think about that. Maybe I can check that. But it comes to having a relationship. And I realize that it can sometimes feel hierarchical, really, you know, but we want to try to level that playing field, because you come in the body you come in and you're experiencing something. And our job is to help see, how does that fit? Do I have a reasonable explanation? And if I'm not sure, is there someone else that I can have check you also to see? Because the last thing I'll say about that is a blood test is not a diagnosis, right? So even if you have an elevated blood test, it's not a slam dunk either. I've got to then come back and ask the right questions to see if your symptoms match that condition. But I'm sorry, whenever there's a delay, whether,
Yeah, and that happens. Sometimes things that are going on, they don't become full blown. You may have one symptom of this or that, and again, it's almost like a jigsaw puzzle. In many cases, I would think, because there are still missing pieces. You may have this, but you don't have this, or you have this, or family history, but there are things. So thank you for really explaining and speaking to that. One other thing from one of our viewers is they were asking if you could share what are some of the symptoms that would indicate one could possibly have an autoimmune disease. And we kind of, we've touched on that, but I guess if they're looking for something a little more definitive, would you like to try to tackle that and talk about
sure,
that?
in one sentence, no, that would be that would be challenging, right? Because there are so many ways autoimmune diseases can present. So what I would think about the most is the obvious things, like arthritis is something we will touch on. Painful joints can occur for the most common reasons, even if it's not autoimmune. But if the joints are swollen, puffy, if you wake up feeling stiff and achy. So for example, as a rheumatologist, I spend my days asking people if they can make a fist. If you can make a fist, then the joints are probably not inflamed. But for example, even if I don't know what's going on, but I wake up in the morning and I find I can't turn the faucet, it's hard for me to turn the doorknob, or I really can't close my fingers and it takes a little while to loosen up. Those are some of those subtle symptoms that you might have, what we call an inflammatory arthritis. So instead of just having pain, there's also something else like stiffness or swelling. In the case of what I'm going to call the lupus family, then you might find those similar joint symptoms, but also other things like I alluded to earlier, thinning of the hair. But for other people, it might be a cough that doesn't go away, or, I used to be able to walk 1 mile and feel great, but now I'm starting to get a little bit winded at half a mile. So because remember when we're thinking about these diseases, we're also thinking about what's happening on the inside. It's easy to notice if I have a big rash or if my joints are puffy, but if I'm having those symptoms and other things happening, those are the kind of things that we would want to encourage you to get checked. So skin, joint, and kind of, I'm going to say this, and this is vague, but it's important, which is a kind of a chronic feeling of being unwell. I'm just not up to my normal level, different from mood, depression, those kind of things, just not able to be functioning normally. So that part is very broad. So I'm not suggesting that everybody who has that has an autoimmune disease, but we're looking for those patterns that say there's something systemic going on. So those are some of the few things that I would think of. Frankly, some of the other things are quite obvious. There are certain rashes that look very classic when we see patients. But if you're going along in life feeling well, and then over a period of weeks or months, you begin to notice that something has changed, and then you find these other symptoms that are developing, that may be good indications to go and get checked. I haven't touched, as you'll see, on things like the gastrointestinal things, excessive diarrhea, bloody diarrhea, for example, and I don't mean to get graphic, but things that are obviously different, weight loss, unexplained fevers, these are just clear indicators. And I would say that it's really important, even if you're convinced going in that, I think I have an autoimmune disease, we've got to do the work. So for example, in my field, unfortunately, sometimes our diseases are actually that what we call, it's a mimicker, meaning something else is actually driving you to develop what looks like this skin rash. And that something else could be something else like cancer. So by all means, if somebody comes in with like unexplained weight loss, shortness of breath, the list is quite broad. There are very few times where you come in and at the door, we can say, oh, that's rheumatoid, or oh, that's lupus. That does occur, but please know that even if we're pretty confident, back to what I was saying earlier about not being too presumptuous in the diagnosis, we want to have a broad approach when we first meet, even when you first suspect it, or if we first suspect it, to check. But those are some of the few things that I would think about in terms of the rheumatologic, I would say, autoimmune diseases. The last part I'll say is multiple sclerosis is a little bit different.
Right.
That you can get a myriad of things, sudden vision loss, strange like numbness, tingling areas, but you have to get evaluated because there are so many reasons. These symptoms that can develop are so very common that it's hard to have that confirmatory diagnosis just based on what you're experiencing at home. So my thing is we look at trends and we look at changes. And hopefully that kind of helps narrow down some of the ways we would begin to approach, what do I do if I suspect I have autoimmune symptoms?
Right. Absolutely. Thank you so much for that. We're going to take another quick break. And when we come back, one of the things that I want to talk about is diet, exercise, because in doing my research, a lot of researchers actually suspect that environmental factors play a big role in autoimmune diseases. So when we'll come back, we'll talk about what your take is on diet, exercise, and things of that nature. Okay? Don't go anywhere, you guys. Okay.
3 months ago, there weren't enough masks. We were desperately sourcing from all over the world. People were making face coverings from scarves, bandanas, and bits of fabric. Now there are plenty of masks, but some people don't want to wear them. Come on. Mask up, America.
Hi, I want to thank you guys for hanging in here with us. You are tuned into You Didn't Get the Memo with my very special guest, Dr. Eleanor Anderson Williams, who's a rheumatologist, and we're actually dialoguing about autoimmune diseases. Before we went to break, I asked Dr. Ellie when we come back if she would talk a little bit about environmental factors, which researchers seem to think plays a part in autoimmune diseases, but also there's something referred to as the Western diet. So I'd like to have Dr. Ellie give our take, or her take, on, first of all, this thought about, or the premise around, what's happening as it relates to environmental factors that are actually kind of driving what's happening with autoimmune diseases.
Perfect. So thank you for that. And one of the things I like to think about when we think about the environment is even outside of autoimmune diseases, right? Cases of asthma, for example, which is an immune problem, but not an autoimmune one. Cases of asthma are higher in certain communities next to, manufacturing and industrial areas. People who live in these areas tend to have worsened lung problems. And you spoke about the Western diet. I have to say that I know that diet doesn't get a lot of attention except around the holidays, perhaps, when people are thinking, or maybe now with the quarantine 15 that everyone talks about in light of COVID. Our diet is crucial. And I realize that there are not a lot of studies that are broadly publicized about diet. It's not as fancy or heroic sounding as a medication, for example, that can be life-saving, but the diet is the anchor of what you do, right? So for me, when I think about what we call the Western diet, and patients ask about this a lot, so I'm glad we get to talk about that today. The excess processed foods, fast foods, those things are designed for convenience. They're not designed for our nutrition. And I'm a firm believer, and I realize that different rheumatologists may have a different level of passion around this, but I feel very strongly that the food we put in, the quality of the food that we put in matters. There are so many studies that have shown the Mediterranean diet, for example, generally more plant heavy, some lean fish, healthy oils, and things like that. The persons in Okinawa, Japan, that live, average, I think, up to 80 and beyond. The vegetarian or other plant-based diets, clearly there's something about the quality of the food that we put in. And I think that that is a crucial and sometimes either underrepresented or missing component in our treatments. I'm not going to tell you that I think that if your immune system is in attack mode, that changing your diet alone is sufficient. I don't honestly think so. But I do believe that even pre-disease, and then certainly in the midst of a battle, I really would encourage us. I hold myself to that. I try to eat as close to nature as possible. And I think that it makes a difference. How can it not? The fuel must make a difference.
Yeah. Well, absolutely. And when we talk about one, it's good to hear you talk about the processed foods, because I know that right now we're in a pandemic and people think that it's so much easier to run out and to get the fast foods. But I also know that eating the fast foods, that processed food, what it does is it actually causes your body to kick into, more inflammation. And I certainly know that, although I have to admit, I, as a Southern woman, I believe and was raised in cooking fresh vegetables and those kinds of things. So, but I can clearly tell the difference. So for those viewers who are watching, if you guys are out there and you are running to fast foods, look, take the time. I always say, for the $40 that you spent at McDonald's or In-N-Out Burger, even though they say it's supposed to be healthy, just think of what you could have done if you had spent that $40 and you could eat on it literally still at least 2 to 3 days out of the week. So thank you so much for talking about that. But let's also talk about exercise. That's been a struggle for me. And again, just with all of the different things that are going on. And I know that it's maybe a struggle for other people, but I would love to hear your take on how you counsel your patients as it relates to exercise, because a lot of people think you got to go out there and be a marathon runner, right? You've just got to be out there all the time. But what do you say to your patients as it relates to exercising and the importance of it?
Yeah. Well, you've set that up beautifully. It is important. Take, for example, just the more common form. So let's pause, not even from an autoimmune perspective, just regular wear and tear, what we call degenerative or osteoarthritis. As we age, sometimes our cartilage shifts and changes, we get more joint pain, etc. Even in the case of osteoarthritis, we know that exercise helps. Our joints are made such that the cushion, the cartilage, they get their nutrition and their nourishment from the surrounding environment. And if I'm moving and I'm active, that improves blood flow to the area. So bear with me, I'm a nerd at heart. So I think about these things more than just the, yes, you should exercise. But when I'm talking to patients, I literally tell them, hey, you want to nourish your joints, and that happens by movement. Now, listen, I know I'm a rheumatologist. I know that I'm talking with people who sometimes have chronic pain, but it's particularly difficult if the disease is out of control. So if you're flaring, we're talking about when the disease is stabilized. Mm-hmm. We want to make sure that exercise is part of your treatment. I consider exercise as important as, honestly, any prescription I write. And exercise, I say the same thing. I'm not asking you to run a marathon. In the case of aquatic exercise, for example, and I come to that directly because I tell people, I'm not asking you to walk on the water, but I'm asking if you'll consider walking in the water. Even if I'm not a swimmer, I can walk in waist-high water. The reason I bring that up as one of the first things as a rheumatologist is because I'm conscious of the fact that if I ask somebody to go pound on the pavement, with a bad knee or sore back or the things, that's a losing proposition. But if I can give you an exercise that you can do, right, and it's not as jarring on the joints, you can get the joint supported, for example, in that way, that gives us hope that we can try that one. Or a stationary bike, things that are low impact are often a good way to start. That is good for your heart, and it's also good for the joints. But I would have to say that in 2020, and certainly before that, but now as I think about it, we also know that there's more. We should consider things like gentle stretching, things that are going to improve our flexibility, what we call mobility. Because after all, if I strengthen the joints, like around my knees, let's say I have knee problems, if I strengthen the support structures around my joint, that's going to potentially help me stave off surgery and more damage. So things as simple as holding on to the back of a chair at home and doing gentle chair squats. If that's what I can do, then that's one way that I can begin to build strength in this area. So I encourage my patients to exercise as many days of the week as they can. I don't say 3 days, because if I tell you 3, you might only do 2. So I'm going to ask for at least 4. And I'm not saying you've got to go 60, 90 minutes. You don't have to CrossFit unless you like that kind of thing. Start with 15 minutes. Then do another 15 minutes at the end of the day. So if you don't have a full 30 minutes in the morning, then do 15 and 15. You can go for a walk. Never underestimate the power of the simple. It does not have to be complex. So my favorite exercises that I recommend are just walking. You can even walk with 2 water bottles. That gives a little resistance, and then drink the water. You have a lighter load home. Aquatic exercise, particularly if you can find a heated pool to support the joints. And then something that has to do with gentle stretching and muscle building, because please remember, as we age, we're losing muscle mass. So if I weigh the same as I did a decade ago, but I haven't been working on building muscle, then I by losing that muscle, I'm also losing perhaps a sense of balance, because my support structures have been weakened. So I consider exercise a crucial part of treatment. I'm happy to go on and on about exercise, but I do know we do have some time constraints, so
Right.
I'll pause here.
Right. Well, the thing is that you were able to encapsulate what we hear, because a lot of times, that's one of the things that physicians always ask: do you exercise? How often do you exercise? And it's something about when somebody says you need to do this, as opposed to the encouraging way that you are couching it and telling people why. It definitely makes a difference. And I don't know, you're not my doctor, but I'm sitting here thinking, wow, I would probably do more the way that you've talked about it. Aquatic exercise, no doubt about it, in a heated pool. And with COVID, I was not able to to do that. But those are the things that you talk about are simple. Actually, it costs you nothing. You got a chair at home, if you got a stationary bike, if you can walk in your backyard. And I love the fact that you're talking 15 in the morning, 15 in the evening, because my whole thing is, gosh, I don't have enough time to get in 30, 45 minutes. But what I have found is breaking it up during the day. It's made a huge difference. So I want to thank you so much for that. And so, we have a couple of questions. Someone wants to know what's your take. So I guess if you could, in 90 seconds or less, what's the doctor's take on the use of saunas to help bones and muscles? And basically, is there any benefit to the use of saunas?
I have to say, I know that in Europe it's used quite extensively. I think my take is that in terms of heat, I kind of think about our bodies like rubber bands, too cold and I'm stretching, that I'm prone to injury. But I like the idea of the sauna being an area of you're sweating out some of the toxins, but also you can improve mobility. Think about what it feels like at the end. If I were to warm a rubber band, it's far more pliable and movable than if I just take a rubber band from like a freezer and try to snap it. So I don't know that there are any studies that show, how much the benefit is. I think that definitely there is some benefit in those kind of environments for the reasons I've explained, that mobility and sweating and so forth.
Yeah. Okay. Thank you so much. Real quick, Dr. Ellie, vaccines. We hear a lot about that. And I know that back in 2015, there was this theory around the hygiene hypothesis, right? Basically, our kids are so clean that, having the experience of being exposed to certain things is actually had a negative effect. So, do you have some thoughts around the role that vaccines play, and especially as it relates to parents who, kids can't get a germ, and is that healthy or not healthy? What are your thoughts?
Sure. So I'm going to preface by saying I have a smallpox vaccine scar. I remember it like it occurred yesterday, and that was quite some time ago. That is the first disease that was eradicated because of vaccination. Polio, we were close, but as I understand in 2020, we've lost ground. So there's a medium between the touch me not, right, the people who live in a bubble, and getting vaccines. And I think that's where I tend to operate, not on either extreme. Realize that vaccination is important as a rheumatologist, in my opinion, because our patients are more susceptible to infections. And so vaccines are a practice run, right, for your body to help fight infection. So vaccines work basically because instead of having the full-blown, we shouldn't want to have full-blown measles. But if my body can run through a simulation of what it would do to fight the measles, that's what it does when you get the vaccine, then that offers me protection. All that means is if the body were to now encounter measles, it knows what to do and it handles it. The same for the different strains of flu and so forth. So I think that there's a happy medium between letting your child play in the dirt, yes, please, giving them a broad exposure to different fruits and different, foods and different things to help build a healthy immune system. But for the things that are called pathogenic, the things that can cause, death or severe deformities and things like that, those we do want to vaccinate against.
Yeah. Okay. Thank you so much. Real quickly. I cannot let you go without discussing this. Let's talk about the sick role in relations to family members. And if you will explain, when I use that term, sick role, right? You and I had that discussion. So talk just a little bit about the sick role in its relationship to your family.
Yeah, I think this is also really important because I think that, as an observer of patients, and I do, right? I don't just make diagnoses. I am traveling through. I see that patients, for example, if they come in, I always want them to feel like you don't have to prove that you're chronically ill to me. Very few people, I think, understand fully, and I don't mean this in any way disparaging to supportive family, loved ones, etc., but it's very hard to walk fully the journey of somebody with a chronic illness. And that is because, frankly, after a while, bear with me, it might feel tiring to people, like, how come you're not better? And that puts a lot of pressure on the person who's ill to kind of put on a face, but conversely, when they come to see me in clinic, people are apologetic if they don't have on makeup or some such thing. So it's a strange world to live in, I think, at times for people who are battling chronic diseases, because you don't know how to be at times, if that makes sense. If I put on makeup, I hear this a lot, or if I try to do something, if I'm happy today, it's like people don't believe I'm also chronically ill.
Absolutely.
And I think we cannot afford to invalidate people in that way. I know that there's a whole community around what are called invisible illnesses. Mm-hmm. Dealing with a chronic illness is brutal because there's a part that's this ebb and flow, but I always feel like I almost see my patients looking over their shoulder like, I feel fine today, but I don't know how I'm going to feel tomorrow.
Right.
And I think that's really difficult. So for the viewers listening, I would say on twofold. If you're the patient, just know that we see you. And if you're the family member or the loved one trying to be supportive, lots of grace. One of the things I read once was treat yourself, and I would say treat your family member with tenderness, optimism and compassion. One day they may be up and to climb mountains, and the other day they may be flat in bed. They have to find a sense of balance, and that may differ from day to day. I think that if I'm not able to go out and do things, well, no one can now in the pandemic, but if I'm not able to go out and celebrate or do things with people, sometimes people tend to withdraw because they don't know how to relate. So I just say the person that you love and care about, they're still there. They're just going through a little bit more, and day to day may be a little bit different, but give them permission, I would say, to just be. If they're fully glammed up and they say they feel terrible, they feel terrible.
Right.
And so forth. So that's when I think of the sick role, I really try to be cognizant and sensitive to that, because I want people to feel supported really here. Does that make sense?
Yeah, absolutely. And I'm just happy to hear you say that, and for us to be able to talk about to the viewers, because it is using myself as an example. I mean, today, oh wow, I feel good, but tomorrow or later this afternoon, it's like, wow, what is happening, right? So, but the thing is, I think it's really important for the patient that's going through it to also be their authentic self and to say, you know what, I woke up this morning, I felt great, I did a number of things, and this afternoon, I feel horrible. That's real. It happens. But again, like I said, I love the fact that the family members need to also just be a bit more empathetic and understand that. So thank you. Your last parting words for people. What do you want viewers to take away from our discussion today? What would be those one or two things?
Your health matters. It is a partnership between you and your clinician. You work together really to develop a plan, and it's a journey. It can be a challenging journey at times, and there are so many moving parts, but I would say be encouraged because there are so many avenues of support. We shared earlier about there are different foundations that can be of support to you based on disease-specific things. And there are day-to-day things that you can do. Treat each new day as a new opportunity. We spoke about the lifestyle things that you can do as you manage your care. And then again, I come back to, and I end again with partnership. That's really the key to me, is knowing that you have a team. These things can feel very isolating at times, but if you know and you're confident that you have a team, then we can get through literally anything when you know you have the support that you need. Hold us accountable and hold yourself accountable too.
Yeah, absolutely. Dr. Ellie, I want to thank you so much. The comments, all of you who are tuned in, the people are just continuing to comment about how this is such a great topic, and thank you. I want to thank you so much for, being willing to come on and to talk with us as it relates to autoimmune diseases. Don't go anywhere. I want to say to you, the viewer, thank you guys so much for tuning in. I always say is if you didn't take anything away from today's show, it's you who didn't get the message. Until this time next week, which we will not be on, which is Election Day, November 3rd, but the following week, we're going to be talking about infertility and fertility. And so if you're having some of those issues, I really want to have you tune in and make sure that we continue to bring you, the viewer, relevant, factual, mainstream information. Remember this, the quality of your life is determined by the decisions that you make. Until this time, next week after next, guys, be well, be blessed, and continue. Remember, we're still in a pandemic, so mask up, practice social distancing, and excellent hand washing. God bless you all.